Hello, I'm Richard Bogan, and on behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's educational activity entitled Hitting Refresh on Excessive Daytime Sleepiness, Managing Patients with Narcolepsy and Idiopathic Hypersomnia. Today's program is supported by an educational grant from Jazz Pharmaceuticals Incorporated. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points, so make sure you engage in today's event, answering polling questions, submit questions, and provide your feedback. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as CME for MIPS improvement activity, so please make sure to participate and provide examples of how you will change your practice, and CMEO will send you confirmation of your participation, which you can submit to CMS. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using an enhanced platform today that allows you to save the slides, take notes on the slides, answering polling questions, and send us your questions. Please look at the tabs on the left side of your screen and give us your feedback on the program and the platform as well. So again, I am Richard Bogan. I'm president of Bogan Sleep Consultants, LLC, medical officer of SleepMed Incorporated, and director of SleepMed of South Carolina. I'm also associate clinical professor at the University of South Carolina School of Medicine in Columbia, South Carolina, not Columbia, South America, and associate clinical professor at the Medical University of South Carolina in Charleston, South Carolina. I'm pleased to be joined today by Yves Devalier, professor of neurology and physiology at the University of Montpellier and director of the Sleep-Wake Disorders Center, Department of Neurology at the Guy de Chauliac Hospital in Montpellier, France. Welcome, Yves. I know it's very late and I slaughtered the name of the hospital, but welcome.
Many thanks, Rick.
I'm also very pleased to welcome Terry Weaver, Dean of the College of Nursing, professor of the Department of Biobehavioral Nursing Science in the College of Nursing, and professor in the Division of Pulmonary Critical Care, Sleep, and Allergy in the Department of Medicine at the University of Illinois, Chicago, in Chicago, Illinois. Terry, thank you for being with us today.
Thank you so much, Rick. It's a pleasure.
I'm really excited to have both of you here, and to frame today's discussion, let's start by reviewing our learning objectives, the first of which is to differentiate the spectrum of EDS across the subtypes of narcolepsy, both type 1 and type 2. Our second learning objective is to apply data from recent clinical trials to treatment decision-making in patients with narcolepsy. And our final learning objective is to evaluate the impact of emerging agents for the management of EDS in patients with idiopathic hypersomnia. There are a lot of sleepy people out there, and one of those is our first case. This is Savannah, and I'm going to go over Savannah's presentation. As you can see, Savannah is a 26-year-old Black female graduate student. She constantly feels the need to take a nap, and she has 3 to 4 awakenings during the night, but does not have trouble going back to sleep, which is an important point. She describes very vivid dreams, colorful, almost like going to a movie. They seem real, and sometimes they are disturbing. And she often awakens with a sensation of inability to move and impending doom and panic, which she considers to be effectively panic attacks. She has no major problems except for a history of anxiety. She has had a history of anxiety disorder and diagnosed as having attention deficit disorder some years ago as she began to have some performance issues both in school and work. Her previous psychiatric evaluation was performed due to these panic attacks at night and poor concentration. She noticed irritability and mood changes with episodes of fatigue as well. Symptoms actually began in her mid-teenage years, and they were slowly progressive over time. The history of vivid dreams and dream enactment were also occurred and were characterized by talking in her sleep or frequent movements, which upon awakening were usually associated with the dream content. There was no history of snoring. She did not have restless leg syndrome, no history of periodic leg movements. And she also denied episodes of loss of muscle tone associated with strong emotion while awake, sort of a melting sensation. Her psychiatrist had placed her on escitalopram 10 milligrams, which had somewhat improved her coping skills, reduced her anxiety. She was on methylphenidate, which had been titrated over the years to 20 milligrams twice a day. And she noticed that the methylphenidate had improved her memory and executive function and also helped with her fatigue and sleepiness. It did have some problems associated with, she had a little fine tremor. She noticed some clenching of her teeth during the day and maybe some increase in anxiety on occasion with an increase in heart rate. She could feel her heart beating. In addition, she is on oral contraceptives. She had patient-reported outcome measures, and the Epworth score was 19 over 24. As you know, 24 is the maximum. The higher you go, the sleepier you are. Interestingly, we recorded insomnia severity index, which in this case was 19, which is somewhat elevated, which is reflected by her fragmented sleep and her sensation that sleep was not restorative. And then we have this modified FOSQ, a 10-item questionnaire, which Dr. Weaver will talk more about later on. She scored 9.5 out of 20. We want to have a higher score here, and the lower score indicates that there's some issues going on here. On exam, her heart rate's 95 beats per minute. She took her methylphenidate earlier. Her BMI is 31, which is high, as you know. Metabolic studies had ruled out hypothyroidism, anemia, and diabetes. And you can see the European influence on anemia. Her sleep diary indicated that she was typically going to bed right around 2200, maybe at the half hour. And she described a sleep latency of less than 5 minutes, but multiple awakenings in the night. But remember, she was able to go back to sleep when she awakened. Her typical awake time was between 8 and 8:30, though on the weekends she would sleep in later by about an hour. Actigraphy was performed and basically validated what she had described. As we all know, there can be some issues in terms of patient-reported bedtime and awake time and patient perception. Since we're amnestic when we're asleep, we don't always know when we're asleep. She did undergo polysomnography, and at the polysomnography, it was, this was a question, and it was approved by her family practitioner and psychiatrist to hold her escitalopram for about 2 weeks prior to the sleep study. It's actually slightly longer than that. She had discontinued the methylphenidate for at least a week prior to that. And she had a video recording polysomnogram that showed a total sleep time of 420 minutes, sleep latency of 5 minutes. She did have some wake time in the night, had to get up and go to the restroom and had some awake time. Her sleep stage distribution, we would consider to be relatively normal in terms of non-REM sleep and REM sleep. But interestingly, REM latency was 8.5 minutes. She did not have any clear evidence of obstructive sleep apnea. Snoring was really not prominent. Yet she did have an AHI of 4 episodes per hour, which was primarily occurring during the phasic REM episode. She had a little hypoventilation. And with her BMI of 31, she did desaturate to 88%. Her ODI was 4 per hour, but saturation index time was really less than 1 minute. Periodic leg movements were noted, about 15 an hour, with a PLM arousal index of 4.2. The following day, she had a multiple sleep latency test performed. She had 4 naps, and on those 4 naps, her latency on average was 3.5 minutes, and she had 3 sleep onset REM episodes. So Terry, what do you think?
Well, I want to thank you, Rick, for that very interesting case presentation. But I think before we go too far, we really should get some input from our audience to see what they think is the situation with Savannah. So can you all please vote now on whether you think the diagnosis is idiopathic hypersomnia, narcolepsy type 1, narcolepsy type 2, none of the above, or you're just not sure. And we'll reveal the results of this a bit later. Eves, I believe that you also have a case that you'd like to discuss. And so what is the presentation of Janet?
Yes, thanks, Terry. I'm happy to present the French Janet. So Janet is a 23 years old white female with normal BMI about 24. There is no particular medical history, familial or personal, and no history of depression. So the symptoms is quite large. The patient complained about daytime sleepiness since 10 years of age, so she was just 23, so half of lifetime. The onset was quite difficult to pinpoint, with really some difficulties to remember exactly the age at onset. She did have mostly a long sleep at night, and she can sleep 12 to 15 hours a day. During weekends and vacation, she can go to sleep around 11 p.m. with huge difficulty to wake up in the morning, and she requires mostly 5 alarm clocks. She did have rarely naps because when the naps occur, that take more than 1 hour, and with a lot of problem to wake up after the naps. So mostly she tried to not nap. Naps were without any dreams. So sleep inertia in the morning start after the nighttime sleep, but also after the nap. She's never refreshed. The sleepiness is almost continuous the whole day. Because of this sleepiness, but mostly the long sleep at night and the sleep inertia, she cannot have good performance at school and at work, arriving late in the morning at work right now and at school in the past, and all day long she fight against sleepiness. She did have not cataplexy, no sleep paralysis, but some hallucination when she fall asleep, and no real agitation at night. So no argument for REM or non-REM parasomnia. She has no medication right now or in the past, no CNS drug, no drug proposed for sleep. So based on clinical interview, we wanted to go a little bit deeper with some scale, and we use this Epworth sleepiness scale with the score is above 10, but still not very high, is 12. So around the limit, and the BDI to assess the depressive symptom is around 13, so not a big deal, also quite in the normal range. So to go to the diagnosis, we decided to go to polysomnography, as Rick also proposed for Savannah. And what we can see here is that there is a short REM sleep, but the day after, when we asked for that, she was sleepy before the recording. So it's not really a SOREM, and that need to be in mind that when you do have a SOREM or you score a SOREM, you need to be sure that the patient was not sleepy before the recording, and it was the case here. After this, sorry, could you go back? And the sleep efficiency was normal, as you can see, with no pathological AHI or PLMS, both below 5 per hour. After the PhD, we performed an MSLT, and with 5 naps, and the mean was 10.8. So she slept all the time, but it's not very pathological because the mean is above 8, and there is no sleep onset REM period that contrasts to the SOREM at night. So the results were in between, and because of the major complaint about long sleep at night and sleep inertia, we decided to ask for a second polysomnography with a long recording, with 32 hours recording. It's 1 night, 1 day, and the second night in bed rest condition. We published that several years ago in Annals of Neurology for the procedure, if you are interested to see. And here you can see that the patient fall asleep around 11 and 40 minutes. And after, it's very hard to see when she wake up. And look at the first part of the hypnogram, and you need to go to the second line, and she wake up at 3:40. So a huge sleep, with around 10 cycles. After she has no naps. There is very few complaint about naps, as I told you, just 2 very short sleep onset. And after the second night is completely normal, and we wake up after 32 hours of the recording, and she was still asleep. So globally, the total sleep time was more than 20, and no real naps. So, and the second night was associated with normal sleep. So there's no clearly a long sleeper during the first night and no sleep the second night, as we can see, without any disorder.
Thank you, Yves, for sharing with us another challenging case. Again, I'd like the audience to weigh in on what you think the diagnosis would be for Janet. Is it idiopathic hypersomnia, narcolepsy type 1, narcolepsy type 2, none of the above, or you're just not sure? So you can go ahead and vote now. So let's talk a little bit about the impact of narcolepsy. About 200,000 people in the US have narcolepsy, and it is, after sleep apnea, obstructive sleep apnea, the most common cause of excessive daytime sleepiness seen in the United States sleep centers. On average, there's about 5% of patients that are seen have primary diagnosis of narcolepsy, and often it is present as a comorbid condition with other primary sleep disorders. As I've said, it is common in sleep apnea, with 25% of the patients have sleep apnea and narcolepsy. The issue, however, is that only 82% of patients with narcolepsy receive a diagnosis after about 1 year from symptom onset. And a third, unfortunately, suffer for more than 10 years before they're diagnosed. So it's very important to be able to know the signs and symptoms so that these individuals can more quickly be diagnosed and treated.
Thank you, Terry. There are a lot of sleepy people out there. I mean, we know that probably 25, 30% of the adult population, depends on, the study design, that people are sleepy. And also, primary care practice, people are tired of hearing me say this, but a primary care practice has about 2,500 patients and maybe 3,000, and a third of those patients, or 30%, are sleepy. Yet narcolepsy is relatively rare, 1 in 2,000. So we have to give the primary care practitioners a break. They have a whole lot of sleepy people, and embedded in there maybe one narcolepsy patient. So thank you for that overview, Terry, because sleepiness has, we're going to explore the impact on quality of life. But Yves, before we get into that, can you talk about why are these people sleepy? What's the difference between type 1 and type 2?
Yes, thanks, Rick. So the pathophysiology of NT1 is quite clear. There is a loss of orexin neurons, or also named hypocretin neurons. We do have 80,000 orexin neurons in the brain, and that disappear in patients with NT1. There's a destruction with a presumed autoimmune-based process, because it started at a young age, at onset, with a predisposed genetic background. And because of this destruction, that leads to a orexin deficiency within the CSF, and this is one of the biomarkers. We will come back on that in a minute. And because of this absence of orexin in the brain, that explains the daytime sleepiness, the sleep onset REM period, and the cataplexy. So the pathophysiology of narcolepsy type 1 is complex in terms of the autoimmune process, but there is a big biomarker that is really helpful for the diagnosis and is included in the ICSD-3 criteria. For narcolepsy type 2, the story is less clear, and there is a lot of recent data, and we did also one in my lab published in Sleep this year to look at the neurotransmitters NT2, NT1, and IH, and to look at so the norepinephrine, the dopamine, the orexin, the histamine, the GABAergic stuff. and their metabolite, and it seems to be normal within the CSF. So it's very hard right now to detect a biomarker which is associated with NT2. The two main hypotheses, the three main hypotheses is imbalance between this sleep neurotransmitter and wake neurotransmitter, but not just one in comparison to NT1. Second hypothesis is a partial lesion of orexin neurons, just 20% of them has been destroyed, contrast to 90% of them destroyed in NT1. And the last one is circadian disturbances that may explain the high REM sleep propensity. So, and these three hypotheses are not exclusive and could be mixed together. So far it's more complex to be sure of the neurobiology of NT2.
Yeah, thank you. So we do have a question. What happens if you have a type 2 narcolepsy patient, no cataplexy, but they're sleepy, and you do a lumbar puncture and they have low hypocretin levels?
So the answer is quite clear. In this population, it cannot be NT2 anymore. I will come back in a minute with the definition, but if you do a lumbar puncture in patients without cataplexy, in 20% of them, they will be with orexin deficient, and that need to be renamed NT1. So,
Gotcha.
And orexin deficiency is NT1. It cannot be NT2, even if there is no cataplexy.
Got it. Well, it's interesting. I mean, orexin certainly downstream excites monoaminergic amines and other regions of the brain to help stabilize wakefulness. So it has a huge impact on many body functions, autonomic tone and hypothalamic pituitary axis and other things. But these individuals have state instability, both awake and sleep, through this process. But now that we understand more about the neurobiology, Yves, can you tell us how that translates into our definition of type 1 and type 2 narcolepsy?
Yeah, so far since 7 years right now, is 2014, the ICSD-3 criteria for NT1 is, as you can see on the left part, is excessive daytime sleepiness for at least 3 months. That is unclear why 3 months, because you can detect and diagnose patient with narcolepsy within 2 weeks, but this is what is in the criteria so far. And in addition to this item E, there's the item B, which is cataplexy and positive MSLT. So cataplexy need to be clear, and I will come back on that in a minute, what is really cataplexy. And positive MSLT is low mean sleep latency below 8 minutes and at least 2 SORM on the 5 naps on the MSLT. And that may include right now also the sleep onset period during the polysomnography. So this is cataplexy and MSLT pulled together, and or the low orexin measurement. And you need to standardize with the Stanford measure to be sure of the cutoff value below 110. Narcolepsy type 2 is a little bit more complex, and the same criteria for daytime sleepiness, that's fine. Same criteria for positive MSLT, that's fine. No cataplexy, for sure, that's fine. But item D, you need to measure orexin, also name again hypocretin, and that need to be above 110. So the normal is 200, so you can be in between. You cannot be below. It's a question asked a few minutes ago, and if you are below, you are renamed NT1. And item E is really an issue, and the complaint, because there is no biomarker, again, there is no cataplexy, clinical biomarker, and orexin, real biomarker, you need to exclude that the main complaint of hypersomnolence is not explained by another condition, namely sleep deprived, OSAS, delayed sleep phase syndrome, and drug intake or withdrawal, such as antidepressants stop a few weeks before the sleep recording. So that's a big concern, how to exclude these other causes that may trigger these results on MSLT.
Yeah, that's a very important point, because so many of these individuals, phase delay and insufficient sleep can trick us, as you well know. And we talked earlier about how many sleepy people there are out there. And you would think narcolepsy would be easy to diagnose, someone who's sleepy and has all these REM dissociative symptoms. Why Why is it so hard to diagnose? What are some of the other diagnostic considerations?
Yeah, you make a good point, because EDS, excessive daytime sleepiness, is very frequent symptoms, also as Terry reported, and this could be 15 to 20% of the general population. And here we are discussing about rare disease. So for sure, when you do see a patient with a sleepiness complaint in front of you, you need to exclude first OSA, sleep deprived, poor sleep hygiene, depression, substance and drug intake, mostly CNS drug for sure, like benzo and Z drugs. So that need to be excluded, because these are frequent comorbidities or disorder that may explain the main goal, the main symptoms the patient go to see you, and you cannot think about narcolepsy just in presence of daytime sleepiness. After, there is other disorder, hypersomnolence disorder, namely idiopathic hypersomnia. Klein-Levin is a different story, because it's a periodic problem, and you need to have in between episode normal sleep duration and absence of daytime sleepiness. Periodic Lyme movement disorder is different story, and you need to record sleep to be sure of the diagnosis, and they are less sleepy than the other condition. Circadian rhythm disorder, that's a big deal, because age at onset of narcolepsy is around adolescent or young adults, and there are almost phase delay associated with sleep deprived because of media awareness and smartphone and so on. So you can see a patient sleep deprived with circadian rhythm. They go very bad late in the bed, and they wake up very late in the morning. So that exists. And behavioral symptom of daytime sleepiness, irritability, aggressivity, hallucination, that may exist outside of the narcolepsy spectrum. So really, you need to focus on what is daytime sleepiness with number of naps, short duration of naps, dream content of naps, and to be in a refreshing condition after being sleepy after the naps. In that, need to be in mind that that could be narcolepsy. So the presence of excessive daytime sleepiness is not enough to think about narcolepsy. You need to go in a little bit more in details about the phenotype of EDS. And for sure, what is really helpful is to look for cataplexy, because cataplexy is present in 80%, 70 to 80% of patients with narcolepsy. And it's almost never exists outside of narcolepsy. Very rarely in orphan disease like Prader-Willi syndrome, Norrie disorder, but it's very rare. So when you do see a cataplexy, because in front of you, because of the good clinical history, or because of video type, you need to think about narcolepsy. But sometimes cataplexy is not typical, and you need to think that long cataplexy above 2 minutes, if it's just on one side, unilateral, is the episodes are very rare, around less than 5 lifetime, as an example. If there is some in between consciousness during episode, if there is no trigger, or just negative emotion. Mostly, if you do see that, it cannot be typical cataplexy. So typical cataplexy is a loss of muscle tones triggered by strong emotion, mostly laughing. You need to go to HLA-DQB1 or 602 if you have any doubt. And if it's negative, it cannot be cataplexy, except for extreme rare cases. But that is very helpful because it's easy to deal with. And if you have any doubt, you can go also to CSF lumbar puncture, but it's a little bit more invasive than the HLA. So HLA is of interest if it's negative. If it's positive, it could be 25% of the general population, so it's less helpful. But if it's negative in presence of cataplexy, it should not be cataplexy, again, with some exception. And in front of cataplexy, you can have also to think about differential diagnosis, mainly epilepsy, hypotension, and psychogenic. It could be also functional story. And for hallucination, when it's very a huge complaint, you need to think if it's not really related to sleepiness. Sometimes the patient may complain about hallucination during the day, nothing to do with sleepiness, and you need to think about psychosis, schizophrenia. And when it's at night, in the middle of the night, there is some overlap with NREM parasomnia, namely night terrors and sometimes panic attacks, depending on the content of the hallucination.
Yeah, you raised a good point there. But you know, our patient Savannah was complaining of panic attacks in the night associated with sleep paralysis. So, not knowing, you know, feeling of impending doom and can't move is a scary thing. So, um, and as you well know, people who are sleepy have trouble with executive function, thinking, memory, focus, concentration, mood, etc. How does that interact in terms of obscuring the diagnosis?
So yes, the complaint of daytime sleepiness again is very frequent, and narcolepsy is rare. And an additional problem is the delay to be diagnosed. And in Europe, we did the studies that still right now it's 8 years as a median to be diagnosed. So it's rare disease, but not all patients are diagnosed, and with a long delay to be diagnosed. And in between, they are not diagnosed because they are misdiagnosed. And in 60% of the cases, they are misdiagnosed because of comorbid symptoms in addition to daytime sleepiness and cataplexy. And the primary care think about disturbed nighttime sleep, so namely insomnia, and Savannah also did have some insomnia that may be disturbing for the physician. OSAS, periodic leg movement, REM sleep behavior disorder, that may come from the narcolepsy presentation because it could be associated in narcolepsy, but it could be also a differential diagnosis. Insufficient sleep, ADHD, and also we discussed already on IH, idiopathic hypersomnia, drug intake. And for that, when you do see some patient with this complaint about ADHD, drug intake, and insufficient sleep, the primary care physician will think about this frequent condition may more explain the complaint, and in this condition, narcolepsy will never pop up and never think about. Epilepsy and syncope may be confused, as I discussed already, with cataplexy. So 3 points, rarely diagnosed, so underdiagnosed, long delay of diagnosis, and a lot of other conditions that may mimic and the symptoms, and therefore at the end the physician think about another disorder.
Excellent. You know, I think we're getting lots of questions, and for the sake of time, I'm going to filter some of these and study them a little bit as we further discuss. But we talked about sleepiness, Terry, and while these are not diagnostic tools, they give us some idea of quantifying the degree of sleepiness. Will you just discuss these tools that we use?
Yeah, thank you, Rick, because we talked about in both these cases the impact of sleepiness and these people's ability to just conduct their daily lives. And we need to have measures that we can use not only to look at the symptom of sleepiness, but also their daily functioning, and to evaluate the impact of treatment, which we'll talk about later, and whether it's successful in having any effect. I think we're all in this business to improve the patient's daily lives and not just to change their physiology. So we have two tools that we want to highlight. One is the Epworth Sleepiness Scale. This is the most frequently used scale to measure self-reported excessive daytime sleepiness. It has a 4-point Likert choice and 8 different situations, like reading, driving, you know, all kinds of somnolenic situations that could bring on sleepiness. And it can be used, I said, to monitor progress and the impact of treatment. The other is the Functional Outcome of Sleep Questionnaire, which I had developed, and it really asks about how difficult is it for you to do a task because you're sleepy and tired. So it puts the sleepiness within a context of several different daytime activities. There are the FOSC 10, which is the shorter version. It's 10 items. It has test, retest, reliability, internal consistency, and has been used globally in randomized clinical trials and clinical practice. And there are 5 domains that are assessed: general productivity, which is getting general work accomplished; activity level, being able to maintain the same kind of energy as your peers; vigilance, being able to do those things that are certainly require more attention and concentration and memory. Social outcomes, being able to socialize with individuals and get out of the house. And then importantly, intimate and sexual relationships, because that's also affected by sleepiness. So it's important to have these tools available so that you can understand the impact of the disease from the patient perspective. Helps with a diagnosis, because sometimes sleepiness may be misattributed or masked, and putting it with the context of daily activities helps people think, yeah, I am sleepy when I do that. And they're simple to administer and allows us to be able to monitor progression as we institute treatment.
Thank you, Terry. I mean, basically, is this patient sleepy, and how does it affect their lives? And these two tools really help. And I tell people all the time, if you have a patient who's tired, or a patient who's having executive function abnormality, cognition, memory, et cetera, mood abnormalities, or attention deficit problems, as well as sleepy, go ahead and do the Epworth score and figure out whether they're sleepy or not. Because if they are, you can figure it out. And as Eve's talked about the differential, you can figure it out. And if you make the sleepiness better, a lot of other things will get better. But we've learned that people with narcolepsy do have comorbidities, which can make it difficult, in terms of making the diagnosis. Will you talk about those comorbidities?
Yes, and of course, if living with the disease of narcolepsy is not enough, there's also, as you pointed out, several comorbidities that are presented. We mentioned previously sleep apnea. This data comes from a large sample of patients with narcolepsy versus matched controls. And they found that compared to matched controls, there was a 45% increase in those who had also had sleep apnea compared to the controls. As Eve's pointed out, there's mood disorders, headache, anxiety disorders, diabetes, but also obesity, and then other sleep problems like restless leg syndrome, periodic limb movements, and REM behavior disorder. So it's important to be able to know that, to evaluate the presence of those comorbidities and know that it's going to be higher than in the normal population. And that also, as you treat these patients, be aware of the concomitant medications for these conditions and whether there's some interaction or considerations with regard to selecting the treatment for narcolepsy.
Exactly. What about the cardiovascular risk?
Yeah, that's important to consider also, both in terms of the patient with narcolepsy, but also the patient who presents with a cardiovascular problem that's also very sleepy. You want to think about narcolepsy in that population, but there's twice incidence of stroke and heart disease, along with 30% increase in hypertension and 50% increase in hypercholesteremia compared to normals. And this is from that same study. And you can see that cardiovascular disease almost twofold without hypertension compared to normals. And if you think about major adverse cardiac events, again, almost twice as much. These patients also may suffer from heart failure. We've talked about stroke, edema, also atrial fibrillation, stroke and edema in combination. So it's really important to be able to do a good cardiovascular workup to detect whether or not these are present in these individuals.
Yeah, I think these are interesting, and I think we have to be cautious because this is based on claims data and it's observational, so there's not cause and effect. But the point is our narcolepsy patients have other disorders going on, and they tell us that it's a burden to them. You want to explore some of the burden to the patients.
Yeah, that's very important. We know that the impact, especially with hypersomnians, is that the patient just doesn't have any energy, and of course this has an impact on others because they can't get up, they can't do things, and it creates in them this sense of dependence. They really feel that that when they're asked to do things that interfere with their ability to take naps or to just to rest during the night, they can't perform these because they're so excessively sleepy. The sleep inertia also affects their daily routine, and if they have to care for others, that has an impact. And of course, there's the risk of traffic accidents with falling asleep. The individual feels about 35% have reported they don't have the support of family and friends because often, as I said before, this has gone undiagnosed, and so there's lack of understanding on the part of family, friends, and even their work community. 25% have been dismissed from their jobs because people think that they're lazy because they're falling asleep on their job. And that's really hard for them and has an economic cost as well. They don't have autonomy over their work schedule, so they can't create a work schedule that will now enable them to get the rest or to be at peak times of energy when they have to work. And so often they're working when they're the most sleepy. And unfortunately, it also affects their relationships with others. 13% report that they either been divorced or broke up with a partner because of their condition. And that's really quite unfortunate. And we need to really be cognizant of this.
Yeah, I would agree. I'm going to move us on, but I think these numbers sound low to me. And when I see a patient in the clinic, they look normal, and that's, they look normal to their employer, they look normal to their family until they get sleepy. So, people don't always understand the degree of sleepiness, and so these folks do have strategies that they use because of this burden of idiopathic hypersomnia, as well as narcolepsy patients. Eves, you want to comment on that?
Yes, thanks, Rick. So for sure, because there is no drug available, at least labeled for IH, even if we use some as we treat EDS for narcolepsy, but the patient like also non-pharmacological therapy, and especially they try to naps and they cannot fight against sleepiness sometimes, so they are almost obliged to naps. But as I report as Janet's story, the napping strategy is not really powerful compared to narcolepsy because it's often very long, 1 hour, even sometimes 2 or 3 hours, and they are not refreshed after the napping. So they lose time because it's not really powerful and they are not refreshed. So they can increase motor activity, to speak all the time, to try to run or to do many things, to move a little bit around to fight against sleepiness. But again, it's not really effective. And you can try also caffeine, nicotine, many things, but to try to cope with. But unfortunately enough, it's not again enough effective because it cannot cure and solve sleep inertia and long sleep at night. It may be a little bit effective on daytime sleepiness with at some degree, but less again than what we do recommend for a patient with narcolepsy.
Yeah, I just saw a patient last week who tells me that she moves all the time because if she sits down, she just wants to take a nap. And if she takes a nap, it's a long one and she doesn't feel good when she wakes up. So it can be very difficult. We've got some questions on the multiple sleep latency test, but before I entertain those, would you discuss the ICSD-3 criteria for idiopathic hypersomnia?
Yes, thanks. I think that should be also updated soon because the current definition of IH is based on many criteria on the left part. So item E is daytime period of irresistible sleep, need to sleep or daytime lapses into sleep present for at least 3 months. It's exactly the same phenotype definition of EDS in narcolepsy type 1, type 2, and IH. And it's not the case for sure. Sleepiness do not have a unidimensional aspect, and there is no complaint or report about sleep inertia and long sleep at night. So I think that should be updated. For the item B, it's less than 2 SOREMs, so it's 0 or 1 SOREMs. And again, this is an issue because when you do an MSLT with 2 SORM, you can think about narcolepsy type 2, as we discussed a few minutes ago. But if you redo this MSLT few months after for many reasons, especially because the mean sleep latency is 9 minutes, not below 8, and you wanted to do that again, and you did see 1 SORM that time and the last time 2 SORM or the opposite. So why do you need to change the diagnosis? So it's not very stable, this 1, 2, 3 SORM. So it cannot be really a definition because it's too much variable. So no cataplexy for sure. Item D is mean sleep latency below 8 minutes. So that's of interest, but again, if it's 8.5, you cannot be diagnosed with IH. So what should it be? It is not nothing. So there's a complaint, and MSLT is 8.5. So the 8 minutes is the cutoff for narcolepsy. Is it really the same cutoff required for IH that need to be solved? And item 2 for the D part 1 and 2 is the total sleep time above 660 minutes, so 11 hours, on 24 hours polysomnography. And unfortunately enough, it is not available in many places all over the world because it's costly, and the procedure to do so is quite hard. So it can be done in some labs all over the world, but few places, but the definition is for everybody. It's international definition and is not a Montpellier definition. And if you do the wrist actigraphy, it tells you something about phase delay for sure, about sleep deprived, but it's not because you didn't move that you are sleepy. So the clinophilia, the term we like to use in France, is you can be in a bed without any moving, but it's not sleep. So I think it's not enough. And item F, it's exactly the same as for narcolepsy type 2, and you need to exclude other etiology that may trigger or explain the complaint of hypersomnolence and MSLT, and the same as we discussed, sleep restriction, mild HI, mild PLMS, low sleep efficiency, and depression, obesity, CNS drug intake. And so it's easy to list, but sometimes it's not easy to be sure. One example about AHI about 12, but if the patient at 12, do you really believe that may explain everything of the complaint? And if the patient has PLMS about 10, as another example, that may explain the huge complaint of the subject. And same for depression, could be a consequences of being sleepy, and with the consequences of being sleepy and not formally the etiology. So sometimes, and obesity is the same, it's not because you are obese that you will be sleepy. So it's easy to say, to list this etiology, but is not always easy to be sure that it is mostly related to obesity or depression and less to IH per se.
Thank you for that. There are 2 quick questions on the MSLT, which you've already covered to some extent. So I have a patient with narcolepsy with obvious cataplexy. I know it's cataplexy. What's the probability I'll have an abnormal MSLT, or the other way, a normal MSLT, non-diagnostic? And then what do I do? And then the other is, I have a sleepy patient with 1 SORM and an abnormal less than 8 minutes. Is that IH?
So the first one on typical narcolepsy, the complaint of sleepiness and cataplexy and normal MSLT, it may be related to the age, first point, because with the age there is a decrease in the number of SORM and an increase in the mean sleep latency. We did publish that 10 years ago or so in neurology. And so you need to stratify by the age. Sometimes there is some noise in the lab, or first night effect or first day effect, or they are also very anxious or stressed about the results and the diagnosis at the end. So it could be not representative one day in the lab than the day in their daily life. So in these cases, you need to redo the MSLT. Another way is that cataplexy sometimes is is not easy to be sure, and you need to record that and videotype, because you can say that you have loss of muscle tone when you laugh, but this doesn't mean that it exists. So you need to be sure that the diagnosis is there. So this is for your first point. And the second point is MSLT below 8 minutes and 1 SORM. Is it IH? It is part of the definition of IH in terms of the exam, but you need to be a clinician first and to believe on the story. And the story tells you about long sleep at night, sleepiness, long sleep, without dreams, with not refreshing naps, and sleep inertia in the morning. And the exam is just to confirm what you do believe with your clinical interview. So it could be IH, mean sleep latency below 8 and 1 SORM, but it doesn't mean that this is IH. It's not enough.
Very, very good. Thank you very much. We have lots of questions. These are great questions too, but we better move on. This next slide is actually one of my favorite, Yves, because as we begin to think about this spectrum of sleepiness, and we have these patients who sound like they have narcolepsy, I call them narcolepsoid, and idiopathic hypersomnia, long sleeper types, et cetera. Can you talk about your algorithm that you use?
Yes, thanks, Rick. If it's your favorite, I can send you as a gift. So I think that we need to move on from ICST straight to a new one, because everything is not clear. What we do know is daytime sleepiness exists for these three conditions, NT1, NT2, and IH. But again, in the definition of ICST3, item E, as I told you, is the same, but it's not the same in terms of the patient complaint, short versus long naps, refreshing, yes or no, dream content, yes or no, sleep attacks, planned naps. That's differ between the three conditions. In narcolepsy type 1, we do see some cataplexy, hallucination, sleep paralysis, disturbed nighttime sleep, obesity, and precocious puberty. So as a complaint that is associated with this short naps, refreshing with dream content. For NT2, it's less clear, but disturbed nighttime sleep, obesity is not well studied, and hallucination and sleep paralysis for sure are more frequent than the general population, but less than in NT1. And IH, again, I do not like the definition in the ICST3, because they focus for the clinical part on daytime complaint, but not on long sleep at night, namely hypersomnia, and about sleep inertia. Agree that some patients do not have sleep inertia, you can have just daytime sleepiness. But in contrast, patients may have long sleep at night with huge sleep inertia, but not very severe daytime sleepiness. Because if you wake up at 1 or 2 p.m. in the day, as Janet, yes, but there is no really time to be sleepy in the day, because there is almost no day. So this is the complaint. After, when you go to the exam, the MSLT, we discuss a lot on MSLT in SORM. For NT2 is almost the same, but you need to exclude sleep deprived. So if you are sleep deprived, you cannot be diagnosed with NT2, but what is the cutoff? Is it 6 hours? Is depend also on time to time and the age of the subject. And for IH, we discussed also about the MSLT with 0 or 1 SORM at max, and the total sleep time above 11, 12, 13. What about the cutoff? And what you can do during the 24 hours recording? Can you watch TV? Can you be on your iPhone? What about the lux? So the luminotherapy and so on. So I think that need to be standardized, and also for sure you need to exclude sleep deprived. And sleep inertia need to be also assessed objectively with some reaction time tests, such as the SORD of the PVT. So based on all of this clinical exam and clinical story, clinical interview, and some exam, you can go to this different disorder. So NT1 is quite clear, and we do have this nice biomarker, namely orexin deficiency and the HLA-DQB10602 in 97% of the population. And in NT2, I separate some with NT2 quite close to narcolepsy type 1 because they could be with HLA-DQB10602. And I told you also that orexin may be in between decrease. It could be 120 as an example, it could be 130. So in between, not normal, but in between. And some patients with NT2 may develop cataplexy also later on if you are lucky enough to diagnose patients soon after disease onset. If you go in the right part, IH, you have the typical IH with long sleep time, so prolonged sleep, high sleep efficiency, sleep inertia. And when there is no really sleepiness during the day, you can imagine a bridge with long sleeper that exists. You can be thin and obese, you can be, tall or not. You can be long sleeper or short sleeper, and long sleeper you cannot sleep 12 hours a day if you work, so you will be sleep deprived. So I think there is a bridge between long sleeper and IH with long sleep time. There is the IH is normal sleep time, or you will be very sleepy during the day with normal sleep duration, and that is a link with NT2. And again, if you do twice MSLT, sometime you will see 1 SORM, 2 SORM, 0 SORM, 3 SORM, and the MSLT could be 7.5, and the other day will be 8.5. So the cutoff of 8 is not enough. So there is a bridge also between IH and NT2. And why I like to go ahead and to move on, and I'm happy that Rick liked that, is to find a biomarker. And if we keep on going with the current definition, we will see no biomarker for IH and NT2. And to define what is IH, as Terry proposed the FOSC-10, we work on the comprehensive scale to measure the symptoms of IH, namely ISSS, that has been published 2 years ago in neurology. And this scale is very easy to be completed. It is 5-6 minutes, is the self-reported questionnaire. And there is some symptoms of sleepiness, daytime sleepiness, sleep inertia, long sleep at night, and the consequences of having these symptoms on daily life in terms of work, social, mood, so performance as a whole. So I think it's of interest to have a scale that include the 3 major symptoms of IH and the consequences of having these symptoms on daily life. And what we did see in this paper is it's contrast and higher for sure than normal population. But the most interesting point is after being managed with drugs for IH, is the severity score decrease. So I think it's more interesting for diagnosis IH than Epworth Sleepiness Scale because it didn't focus only on daytime sleepiness.
Thank you very much. Clearly there are phenotypic differences, and as we begin to define these sleepy people and who they are, what they are, this scale obviously will help us a lot. So Terry, I'll throw it back to you for audience response.
Yeah, let's see how the audience is done with their diagnosis for Savannah and for Janet. So we'll start with Savannah. These were the choices that you had, and I want you to vote and see what the results are.
Second chance.
Well, wonderful. We can see that the diagnosis for Savannah after you had some content has definitely changed to show correct diagnosis of narcolepsy type 1. And so that I'm glad that we were able to share some information that's helpful to understand that. Now, how about with Janet? What about the diagnosis for Janet? What is it? Hypersomnia, narcolepsy 1 or 2, or none of the above? Let's see what you think now. So There's been a big jump in differences from pre to post. Most of you have guessed correctly that it's idiopathic hypertension. I mean, hypersomnia, sorry, idiopathic hypersomnia, and with 71% guessing correctly. So thank you for that. And so we can move forward. I think, Rick, we're thinking about treatment considerations.
Yeah, thank you very much. I'm sitting here chatting, so I better get back to the show. We have tons of questions, and obviously now we're going to consider the treatment options. We're getting close to time, so we're going to have to move pretty quickly here, and I apologize because we have some great questions. But Yves, can you start with some of the treatment options here? Our goals.
So it's the next slide, could be. Yeah, so the main goals to treat narcolepsy is first, for sure, to treat the main complaint, the daytime sleepiness. That is really the most bothersome problem. But you need to think about the other comorbidity or other symptoms and not just to focus on daytime sleepiness. And you need to improve nightmares, hallucination, cataplexy, sleep paralysis, and disturbed nocturnal sleep. And if the patient is not did not have enough good sleep in terms of duration and quality, you will be sleepy during the day. So you cannot just focus on the day. You need to focus on the 24 hours problem. But the goal is not just to manage with drugs, is also to improve the knowledge of the patient to cope with the symptoms on daily life, to reduce the psychosocial and work dysfunctioning, to improve quality of life. So that's require medication, but not only, and you need again to improve the knowledge and habits and to propose some naps, regular schedule, and so on. To improve the safety profile also, and for the patient when he's driving, as an example, and to prevent some car crash accidents, to prevent some side effect about medication, to be sure that your drugs is the best for the patient as a personalized medicine. And of key issue, if we are lucky enough to have time, we can discuss the follow-up and the standardization to be sure that your drug is the best for the patient. You need to evaluate in the correct way. And we did also propose a scale for narcolepsy, namely narcolepsy severity scale. So I think the follow-up is the key concern, and not just to diagnose at baseline and to lose the follow-up.
Yeah, go ahead, Yves.
So yeah, several drugs are available so far. And we are lucky to have a lot of drugs. So modafinil, armodafinil, solriamfetol, pitolisant, sodium oxybate, and the new one with a 92% decrease of salt. And also previous old stimulants, namely methylphenidate, that may be helpful for some cases, mostly some severe cases. So solriamfetol, we did nice study in the past with a nice randomized control trial in narcolepsy to prove that it works on MWT latency, which is really great in terms of improvement, but also on the complaint with the Epworth Sleepiness Scale with a huge decrease of the Epworth with the dose, mostly with 300 milligram, which is not on the market worldwide, but is improved also with 150 milligrams. But the most important point here is that we did publish last year and reanalyze this as a postdoc, the results in patients with narcolepsy with cataplexy in one part and without cataplexy in another part. And as you can see here in the two graph, it's almost the same figure. So it works in narcolepsy with cataplexy and in narcolepsy without cataplexy. It's not named type 1, type 2, because also there is no orexin measurement here. So it's mostly based on the complaint.
Excellent. So,
and in terms of the PGI, we do see almost the same. The patient improve almost in the same way with cataplexy or without cataplexy. So the drugs is really helpful for sleepiness, for patient global impression, in the two groups, with cataplexy and without. This is the take-home message.
Excellent. A new drug there, and then efficacy on the work productivity in narcolepsy. Carrie?
Yeah, thank you. And then that same study that Yves mentioned, it had 4 arms, a placebo, and 3 doses, and was a 12-week study, randomized controlled trial, and patients had excessive sleepiness. And as you can see here, when they looked at work productivity, that there was a profound dose response between and several outcomes between the doses. The dark line is the placebo, and then the turquoise are the 3 different doses. The higher doses, there were more impact, and that is the 150 and 300 milligrams. Now, work presentism, as we say, impairment, was improved at those higher doses, and that is the ability to actually conduct the work when you're there. These patients don't have a high level of absenteeism. That was not found in this study. It's more that they just can't get the work done. And when they looked at the overall work impairment, you can see, again, a very nice dose response where, again, the higher doses had a greater impact in improving just the overall improvement in their work.
Excellent. Yeah, I'm going to, Terry, this next slide that looks at correlation between these functional outcome measurements and some of our objective and subjective measures. I'm going to move on just for the sake of time, but then there actually was a question about what is clinically meaningful change. I wish we had a lot of time to discuss this, but come back and study this slide later on, and then I'm going to ask. I'm going to skip some of the audience response questions because I know we're getting close on time. But Terry, can you discuss, your interpretation of the FOSQ-10 and clinically meaningful changes?
Yeah, so in this, again, it's the same study, and data was pulled from actually 2 studies that looked at solriamfetol, and there was a dose response for the FOSQ-10 in solriamfetol. And so it improved daily function. But the question is, what's important? What's clinically meaningful? And so in this analysis, there were several different ways that was examined, ROC curves, correlations. But the one that I'm presenting here is the mean change in both the patient global impression of change and the clinical global impression of change. And as you can see, when you go across the table, that even for the minimally improved, there was a 2-point increase in the FOSQ-10 relative to the change that was noted by the clinicians as well as the patients. And that's shown in the lower graphic as well. As you move from very much improved to much worse, there's a really nice step down related to the change in the FOSQ. So we concluded in this publication that the minimally important difference is about 2 points improvement increase in the functional outcome of sleep questionnaire.
Excellent. So Yves, let's move on to pitolisant, and I'll ask you to move through this pretty quickly so we can stay on time.
Yes, so pitolisant, as you know, has been reported many years ago in several randomized controlled trials to see that there is an effect on daytime sleepiness and on cataplexy in NT1 and NT2, also for sleepiness. And this recent data reassessed the same data from these 2 randomized controlled trials in focusing on the population, the most severe one, with Epworth Sleepiness Scale above 16, with MSLT, mean sleep on MWT below 8 minutes, and also the weekly cataplexy rate above 15 per 2 weeks, so at least 1 per day. So the question asked was, in the severe population, does pitolisant is really helpful? So if you do see the results in this severe population of sleepiness, there is a decrease of the Epworth from 19 to 13 in the Epworth sleepiness scale with the pitolisant, and 3 points decrease in the control, so in the placebo group. And if you look at the objective measurement on the mean sleep latency, you increase a lot from 3 minutes to 10 minutes with the pitolisant, and 3 minutes only for the placebo. So it works on this severe population. And if you go for the CGI, it's improving also in the same way for CGI for EDS, with the placebo, with the pitolisant improvement compared to those with the placebo for sleepiness assessed with the ESS or with the MWT. And the CGI for cataplexy is also really improving with the pitolisant compared to the placebo. So finally, the weekly cataplexy rate improved, so decreased for sure in this way of reporting the results with the pitolisant, with stable results with the placebo. So this post-hoc analysis is of interest to see that it works also in the more severe subject.
Excellent. I mean, this is through histamine. We got some really neat data coming up. So be patient. This particular study design, looking at the lower sodium oxybate preparation in narcolepsy, was a maintenance of effect trial. So we took patients who are on sodium oxybate, other anticataplectics. You can see the subgroup there, but we treated them to effect, basically, so open label, titrated them to effect or tolerance, and then captured a stable dose period, which is our baseline. And then we randomized them to continue drug or go to placebo. And we asked the question, are they sleepy? Do they get sleepy again, or do they have return of cataplexy? And I'm going to jump in on this slide. And basically, what you see is that there's a difference. The ones who were randomized to placebo actually got sleepier compared to this stable dose period. So again, a signal that these individuals were less sleepy on this lower sodium oxybate preparation in the treatment of narcolepsy with cataplexy patients. And the other is from the lower sodium oxybate preparation efficacy, looking at SF36. Terry is going to obviously be interested in the quality of life measures. We saw that quality of life in these individuals significantly were improved in the lower sodium oxybate preparation. I'm going to move through this other pretty quickly because part of the way of looking at this is the efficacy of cataplexy-free days over a week calculation. And you can see as we titrated these subgroups, and because of time, I want you to go back and study this more, but look at these subgroups in naive patients, other anticataplectics, sodium oxybate, with anticataplectics or alone, transitioned over to the lower oxybate preparation up to that stable dose period. And you can see that they move up to close to 6 days of cataplexy-free days during that time. Sorry, Yves, to steal your thunder on that, but I do want you to comment on FT218, which is a once nightly sodium oxybate formulation.
Yeah, so this is the two exciting results based, as you just reported, on low sodium, and right now here on once nightly sodium oxybate from Avadel. This is not yet published data. So, but this is what we will report in the Congress here, Sleep Congress. So it's two parallel groups, one with the placebo, the other one with this FT218, and with escalating dose starting at 4.5 to 9 grams, again once nightly. And there is a two primary endpoint. This is a 13 weeks trial, and as you can see here, at the primary endpoint is the MWT, and it improved a lot till 10 minutes compared to the placebo, improving for 4.5 minutes. So there is differences, significant differences in the MWT sleep latency, improving with the once nightly. And the secondary endpoint was the cataplexy, for sure, with the same assessment as we discussed, the weekly cataplexy attacks that decrease a lot with the drugs, -6 per week again at the end of the trial, and -5 in the placebo, which is quite large for the placebo after 12 weeks. And what is of interest, as Rick reported, is the interest of the week, the cataplexy-free days. It is another way to report, as we often do for epilepsy, is the day without any cataplexy. That is of interest and should be also assessed with this FT218.
Thank you, Yves. And you know, when we do research, we capture side effects, obviously. And so these are side effects. If you look at the product information, these are side effects you might potentially, Yves, you want to discuss those? Or
yes. So modafinil and armodafinil are almost the same drugs, so I will combine them. So it's mostly at the beginning and mostly related to the dose, but headache, insomnia, nervousness, and digestive issue need to be for sure followed carefully for the safety profile. For the sodium oxybate, there is decreased appetite. This is not really a bad side effect. Could be nice side effect for patients with narcolepsy, which are often obese. Enuresis could be an issue. Headaches, nausea. And so the weight decrease is of concern, especially in kids. But again, sometimes is even a nice side effect. The solriamfetol, there is some side effect, mostly the 2 first weeks after drug intake, and mostly that disappear after time to time. And the most side effect, because you are probably less familiar, it's a new drug, is headache, insomnia, nausea, and anxiety. Pitolisant is quite safe drugs for cardiovascular disease. We will come back on that in a minute. But side effect, insomnia is frequently reported. It's once a day in the morning, and sometimes the half-life is too long and they can have problem of sleep at night. And anxiety and nausea exist. And lower sodium oxybate is almost the same as for sodium oxybate, except the cardiovascular aspect that we will discuss in a minute.
Yeah, thank you, Yves. Special considerations quickly. Modafinil, armodafinil metabolized through the liver. So it does activate certain liver processes. So if you're on oral contraceptives, it reduces the effectiveness. Methylphenidate is Schedule 2, so it does have higher abuse potential and has some sympathomimetic effects. Intolerance is another issue. Solriamfetol is excreted through the kidneys, so we don't have the interaction with birth control, but its abuse potential was compared to phentermine and was no greater than phentermine. We saw data on the 300 milligrams. There's actually a question about 300 milligrams and solriamfetol. The FDA did not approve that dose. And much like modafinil, solriamfetol, we want to monitor heart rate and blood pressure because there could be some sympathomimetic effect in certain individuals. Pitolisant's interesting because it does have hepatic metabolism, and we have to take into account QT intervals if we have a drug that has some inhibitory effect on the 3A4 system, might increase the drug exposure to pitolisant. Otherwise, not too much concern. It's not a scheduled drug, so this is amazing. We now have a wakefulness promoting medication that works through histamine, and it's not scheduled. The sodium oxybate preparation, as we said, is when you're on 9 grams, you get about 1.6 grams of sodium. And it is a CNS depressant. And as Yves pointed out, with all these drugs, we want to monitor any CNS side effects because there are always outliers, patients who may have mood disturbance or other issues with these drugs beyond the headache, dizzy, nausea thing that we see. The lower sodium oxybate, pretty much the same side effect as the sodium oxybate, but it's 92% less sodium. So that's important in our individuals who may have comorbidities. So Yves, our patient Savannah, who has type 2 narcolepsy, I think some of you thought she had type 1, but she had no cataplexy. Would you discuss your treatment considerations in her?
Yes, so thanks. Can we go to the previous slide? So, sorry. So there is a lot of possibility right now, and that's good news. And we need to go to personalized medicine for not to treat at the first line narcolepsy with one drug, and if there is a failure for efficacy or safety, we need to go to the second line. Now we need to discuss at the first line which is the best for the patient in terms of the severity, in terms of the comorbidity, and the safety profile. So a few examples here. For LXB, it's nice for severe cataplexy and disturbed nighttime sleep, and obesity if there is no sleep disorder breathing, because LXB may work on that. And for moderate EDS, because mostly could be not enough for severe EDS. And with some concern about comorbidity, about cardiovascular effect. For pitolisant, it's moderate EDS and moderate cataplexy. And it's nice for the patient with psychiatric problem, depression, and cardiovascular past history, because there is no interaction with, but sometimes it's not enough, so it's why it's called for moderate symptoms. Sodium oxybate is mostly the same as low sodium oxybate, except for the comorbid cardiovascular disease. We want to not propose sodium oxybate in this condition, especially severe hypertension, but for LXB, you can cope with. For modafinil, it's really effective drugs. We know these drugs for decades. It's a French drugs, and so it's effective for severe EDS, but not really for cataplexy. But you need to be cautious about blood pressure, especially a cardiovascular risk. For the solriamfetol, it's very potent drugs for severe daytime sleepiness. It's really effective on MWT. But for cataplexy, there is no key effect, and you need to be sure about the safety profile for cardiovascular risk that may increase the dose, increase the blood pressure, but especially with the 300 milligram, which is not on the market. And for methylphenidate is of interest for resistant cases because it's scheduled drugs, schedule 2. So you can propose that for very severe and resistant patients for sleepiness, but it's of interest also because of this oral contraception, and modafinil is contraindicated for that.
Thank you, Yves. It's nice to hear from the learned clinician these results. We're going to skip the audience response data because I do want to get to idiopathic hypersomnia, because we have some treatment considerations for Janet and some really important information here. New data, quite frankly. So Yves, would you discuss treatment of idiopathic hypersomnia?
Yes, so far it's quite clear, because we treat EDS in IH as we do for narcolepsy, because there is no drug specifically approved for IH. But unfortunately enough, with the current drugs, we cannot treat long sleep at night and sleep inertia with the modafinil, the methylphenidate, the pitolisant. And for the sodium oxybate, we will discuss on that in a minute. And for the clarithromycin, I have no personal experience. It's based on the in-between results, I may say. But I have no personal experience, so I'm not sure. I didn't try.
Yes, thank you. As we look at the trials that have been done, I mean, there have been a number of trials. Most of these are investigator-initiated trials, but this is here for your reference to review later on. And for your review is a brief bit of data on modafinil and looking at the efficacy in idiopathic hypersomnia. But as I said, most of these are investigator-initiated trials, but we have a trial looking at lower sodium oxybate. And this is a very nicely done, very similar to the narcolepsy trial, where we took patients and again titrated to effect with lower sodium oxybate. So these were patients that met ICSD-3 criteria of idiopathic hypersomnia. We treated them to effect or tolerance. They reached a stable dose period, and then we randomized them to lower sodium oxybate or placebo. And now we get a chance to look at these. These are hot off the press. These are mostly based on abstracts that were presented at some of the society meetings. So this is brand new data, Yves.
Yes, I think the design is very well deserved to answer the question asked. And it's complex, as you reported, because there is several arms, but the major endpoint was to compare before the randomized withdrawal period of 2 weeks after the stable dose of taking low sodium oxybate for many weeks, depending on the dose and if it's once nightly or twice nightly. And after stable dose, they go to the 2 weeks randomized withdrawal period for placebo for half of them, and to continue with the drugs intake for the 2 weeks again. And here there is one of the primary endpoint. This is the primary endpoint, is the Epworth Sleepiness Scale. And as you can see with the low sodium oxybate is decreased with the open label study and is stable in the stable period study. And at the end of the trial, in the group that continued the drugs, it's stable around 7, and it was 16 at the beginning, and it go up to 14, so in the group randomized to placebo. So really, it's effective on this complaint assess by Epworth Sleepiness Scale. If we look at the PGI, that's a secondary endpoint, it's really improving with the drugs, as you can see here. 88% of subjects are good responders to LXB, and just 20% in the control group. So this is in the randomized 2 weeks period. And we did assess also, there is one missing slide on this idiopathic hypersomnia severity scale, as we discussed already, as a key secondary endpoint, and it works very well in this dedicated scale for this patient, and it's really improving. And here we do see a visual analog scale for sleep inertia specifically, and as you can see here, of interest is decrease is this visual analog scale from 0 to 100, and it was 50 at baseline and go to 25 at the end of before the randomized period, and it's stable in the group that continue the drugs, and it go back to the baseline around 55 in the group randomized to the placebo. So really it's effective on the sleep inertia, on the symptom severity assess on IHSS, on sleepiness assay on ESS. So it's not yet published, but it's really exciting data for this patient, and hopefully we can propose these drugs soon.
Yeah, I would agree. And I know you are a primary author, and this will soon be in the peer-reviewed literature as an article with it. And I'm very much looking forward to that. And so this data has been published in abstract form, and some of the data is actually at the APSS meeting now. So check it out and get some more information. This is really exciting, randomized, large study in idiopathic hypersomnia, recognizing that we do not have current drugs approved by the FDA. So let's conclude. I'm going to move us right along here. And the diagnosis of narcolepsy type 2 and idiopathic hypersomnia is challenging, as Yves has pointed out. And it's laden with misdiagnosis, and considerable diagnostic delays. And treatment options for narcolepsy have expanded and include therapies. Hopefully we've had a chance to cover some of those today, so you can look at that. And may be ideal in patients with medical comorbidities, particularly in terms of the lower sodium exposure. While there are currently no FDA-approved therapies for IH, lower sodium oxybate may soon be the first agent to be approved, which is pretty interesting. Why does this drug work is another story. I mean, in terms of taking it at night in these sleepy people. When making treatment decisions for narcolepsy and IH, therapeutic efficacy on quality of life and functional outcomes must also be considered, as Terry mentioned. As treatment outcomes are not stable, follow-up is really important. Terry, Yves, this has been a great discussion. We could keep on going. Do you have any other thoughts that you want to make before we move on?
No, I think we've been pretty thorough in covering this. I hope that the audience benefited. Certainly, we've seen that we've initially had some impact on their understanding of both narcolepsy and idiopathic hypersomnia.
Thank you so much.
I think we need 1 or 2 hours.
Yeah.
Now, just to say that we need probably 1 or 2 hours again to cover the whole topic, which is a complex topic, but it's 2 a.m. almost for me, so it's also late.
You're our hero. So let's wrap it up with these SMART goals. Utilize evidence-based strategies to improve the differential diagnosis of narcolepsy and IH. Assess a patient's daytime sleepiness at each visit. Assess the impact of treatment options on quality of life and functioning, facilitated by patient-reported outcome measures such as the Epworth, the FOSQ, and the IHSS. Now we have idiopathic hypersomnia scale. Consider patient-specific factors such as cardiovascular risk when making treatment decisions for patients with narcolepsy or IH. We've got lots of questions. Unfortunately, we ran out of time, though I tried to weave questions in as we address some of the information, but we'll try to look at these questions and hopefully we've answered most of them. To receive CME CE credit for today's program, complete the post-test on your screen and then click on the Request Credit tab to complete the evaluation and print or download your particular certificate. Visit the Sleep Disorders Hub, for additional activities on sleep disorders, as well as resources, animations, and patient education. And again, I would really very much like to thank Terry and Eve for an unbelievable discussion and all the work that they do for the patients with sleep disorders. And Eve's is a hero, staying up so late in print. And of course, I would like to thank you, our audience, for participating and providing the best care for your patients. So take good care. Thank you very much.